Okay, hello and welcome, everyone. I'm Hani Mamasani. I'm director of the Northwestern University Transportation Center and also director of the US DOT Tier 1 Center on Telemobility, which is a joint center with UC Berkeley and University of Texas in Austin. It is my pleasure to welcome you today to the third in a series of telemobility virtual roundtables, today addressing e-health and telemedicine, looking at the impact on travel demand. Our Telemobility Center has been looking at the impact of developments in information and communication technologies on travel behavior and travel demand by, of course, examining the changes that have been taking place in human activity through the use of technologies in the realm of telework, e-commerce, e-learning, and today we're looking at e-health and telemedicine. Of course, we as transportation demand, travel behavior specialists do not know very much about health and telemedicine other than as patients and consumers, which is why we turn today to a panel of distinguished experts who understand the supply side of the e-health and telemedicine equation. And our panel will be introduced by Professor David Drenov, who we turned to because we needed somebody who knew more than we did about telemedicine and e-health. And so we're delighted that we have an expert and an authority really of the caliber of Professor Drenov here, he is the Walter McNerney Distinguished Professor of Health Industry Management at Northwestern's Kellogg School of Management, where he is also Professor of Strategy. Previously, he was director of the Health Enterprise Management Program and has spent quite a good bit of his career looking at the structure of the industry, its economics, policy aspects, and so on. So there is no one better qualified to lead today's panel and moderate it than Professor Drenov. And with that, I will turn it over to him, he will then introduce the topic for us and then introduce the panelists. After a series of, let's say, questions that he will be directing to the panel, we will then be taking questions from the audience. But throughout the round table, feel free to send your questions using the Q&A feature of Zoom. We will be monitoring the Q&A feature continuously, and then we'll be taking your questions, which we will then put to our panelists after the initial portion of the webinar today. And with that, I will turn it over to Professor Drenov.
Thank you, Hani, for the very kind introduction, and thank you to all the participants for joining us today. I'll be introducing the panelists in just a moment. First, let me introduce the topic of telemedicine or telehealth. Telehealth promises to disrupt where and how millions of individuals receive their medical care. It's already well on the way to doing so. A May 2020 analysis by McKinsey suggests that prior to COVID, US telehealth spending was on the order of $3 billion annually. Spending has more than dramatically increased in the last year, with one estimate suggesting that telehealth spending in the last 12 months may have reached as much as $250 billion, spurred on in part by changes to ensure payment rules to accommodate the new reality brought on by COVID. Now, this is a lot of money, yet not so much when compared with the overall $4 trillion annual healthcare budget. Can telehealth continue to grow, and by how much? Now, telehealth seems like a new phenomenon, but we could actually trace its origins to the 19th century. For example, in an 1879 article published in the prominent medical journal, The Lancet, researchers speculated that the recently invented telephone could reduce unnecessary visits to doctors' offices. By the 1920s, doctors were using radios to advise shipboard nurses. And Hugo Gersbach, a radio entrepreneur, speculated that one day doctors would conduct medical examinations via video. Telehealth hit its stride in the 1950s when physicians began sending radiographic images over cable. And over the next 2 decades, physicians used closed-circuit television for consultations and diagnoses, what the Massachusetts General Hospital called telediagnosis. As telecommunication technology has advanced, so have the possibilities for remote medical practice. Today, patients can consult with physicians over Zoom, and radiologists in India can read MRIs taken in Chicago. The uses for telehealth might only be limited by our imaginations. Picture a doctor in Norway performing robotic surgery on a patient in Antarctica. Health economists tend to think of healthcare as a local business, where location and transportation profoundly affect access, cost, and quality of care, and could define market winners and losers. Telehealth has the potential to fundamentally change this. But will it? Was this past year the high watermark for telehealth? Can remote diagnoses really substitute for in-person medical care? Will telehealth depersonalize the physician-patient relationship? And will regulatory barriers stop telehealth from fulfilling its potential? Today, we'll explore these topics and more with our three experts. To lead our conversation, we have Richard Bernstein, the Northwestern Medicine Distinguished Physician in Vascular Neurology and the Medical Director for Telehealth at Northwestern Memorial Healthcare. He founded the Northwestern Telestroke program in 2013. Elizabeth Brewster is a director with the Northwestern Medicine Access Division and director of Northwestern's telehealth program. And Bill Ferra is a principal in Deloitte Consulting. Dr. Ferra specializes in technology-enabled transformation to support the advancement of population health strategies and initiatives. Before I ask my first question, let me remind you, you can submit questions at any time to the Q&A tab. Bill, I'd like to start with you. Please describe the current telehealth landscape.
Thanks, David. Well, I guess in a word, I would say exciting and increasingly boundless horizon when we look at that horizon. And I think back in my career, starting in 2008, when I was at UPMC, we launched something called the Center for Connected Medicine, which was really the beginning of an enterprise telehealth strategy. And at that time, we were really bringing together some disparate telemedicine efforts that were more reactive into a more cohesive strategy. I don't think it's hyperbole to say that more has happened in the last 12 months than in those 12 years since 2008 because of the influences that you mentioned, starting with COVID, but then the reaction to COVID with regulatory and reimbursement easement and more hospitable approach to telemedicine and virtual healthcare services. But really, I think that the best is yet to come, and we're just starting to reach that potential. If we think about the way that most organizations have deployed telemedicine efforts, it's really been along three different axes. One is improved access. So really thinking about substituting access by virtual visits, online visits, e-visits, really still substitutive. Some then will go into extended expertise, as Dr. Bernstein will talk about with telestroke or telepsych virtual consults, or you mentioned robotic surgery maybe in the near future. Then we can move into continuity of care with remote patient monitoring and easement of transitions of care. When we start to do all three of those things together, which we are starting to be on the cusp of, then we can truly be transformative. We can have team-based care anywhere, any place. We can involve members of the family from anywhere across the country. We can do team-based rounding synchronously. We can have national cancer care, as you started to allude to, integrated behavioral health programs. And these programs really have no geographic bounds as we start to look into the future. So we're very excited about the way that virtual health has the potential to really create patient-centered care models and realize some of the potential that you were talking about in your thoughtful introduction.
Great, thank you so much for that overview. Elizabeth, why don't you tell us about Northwestern's telehealth program, how it's evolved, especially during COVID, and what you've learned that you could use moving forward?
I think one word that would describe our program is transformative. I mean, prior to COVID, we were doing small pilots and that was it. So we were doing, when we talk about telehealth, as Bill mentioned, there's a number of different types of programs, but the most common thing I think people think of is an outpatient visit with your doctor that you can now do virtually. So prior to COVID, total in the last several years, we were working on a few small pilots where we would do a virtual visit between a patient and a physician in very specific scenarios, maybe related to a post-op visit or travel medicine, but we only did 800 total and we do millions of visits a year. So if you think about that as a proportion, it was, and a lot of what drove that was the reimbursement landscape. So payers were not broadly reimbursing for telehealth services. So it was, again, we were trying to find small pilots here and there until that first week of March hit last year. At that point, then we dramatically transformed as we closed some of our offices and moved our visits virtually. At that time, I think our providers were really using any tool they could find to complete the visit. And then we rolled out a standard platform for how we wanted virtual visits to occur. And then I think as we looked through this year, we're now kind of stabilizing and saying, okay, what do we think this looks like long-term now? So if you look at from September to about a week ago, we have done 260,000 virtual visits, which represents 17% of our outpatient visits. We are now looking at how do we hardwire telehealth into our operations. So if you can think about it, we have a call center that you call in to schedule an appointment. It was not a standard process that we would offer telehealth as an option to patients. Now we're looking at how do we hardwire that in and say, we should be offering this to our patients as if it's their preference to complete this visit via telehealth, we should make sure we're offering that. How do we look at all of our self-service tools where we're allowing patients to schedule online and make sure that we have telehealth there? But most importantly, this year, we're working with all of our specialties and looking at across that specialty, what do our physicians think are the most appropriate types of patients that we want to keep offering virtual care to going forward? So for example, Dr. Bernstein, will talk through neurology and how they're using that, but our oncology department might see it differently. Primary care, we're seeing continually about 20% of our primary care patients opt for virtual. So really, I think now we're looking at, okay, what's long-term? And then we continue to closely watch the reimbursement landscape. A lot of the reimbursement has been approved through the public health emergency. Some payers have added that in permanently, some have not. So I think that's going to be a big driver. And then another sort of exciting area in the inpatient side is this whole idea of hospital at home, where really you could start to consider how you might provide inpatient care in an outpatient care setting. That's a pilot CMS has launched and approved. And I think we, along with a number of large healthcare providers across the country, are looking at what does that mean to start providing inpatient care in a patient's home using all remote patient monitoring and a variety of devices. So it's very exciting.
Thank you so much. Richard, let me turn to you. I sort of have two questions in one. Can you tell us how telehealth has transformed stroke care and whether you're seeing similar transformations in other clinical areas?
Yeah, good question. Stroke is a somewhat distinctive condition in that it's when it comes on, it's an emergency. It's extremely time sensitive because, as we like to say, time is brain. And there are some decisions that need to be made about a patient in the emergency room very, very quickly that have tremendous consequence. And most neurologists, let alone ER doctors, aren't comfortable making those decisions on their own. So that's some of the impetus for how telemedicine has been used to allow a limited number of stroke specialists to provide this acute care across ERs that they could never reach in person. The other thing that makes stroke distinctive is that the neurological exam, the actual visualization of the patient is really a large part of the decision-making process. And so it's not good enough to get a phone call from an ER doc telling me what's going on. It really is it's much richer for me to see that. And the decisions I'm making don't require me to be present to enact. So I may say, give the patient TPA, a clot-busting drug, but anybody can administer that. It's just giving a drug through an IV. That combination makes stroke care the perfect place to use telemedicine. There are a few other examples. Psychiatry is one of them that's already been mentioned, and to some extent dermatology is another very visual specialty where you see it and you know it. What we're learning is, as we try to expand that care to other specialties, you run up against the fact that, for example, for a surgeon, it's great to be able to make a diagnosis over the internet, but then somebody has to do the surgery. And if that expertise isn't present locally, the telemedicine only gets you one step towards helping the patient. So as we move forward, we're trying to sort out what, I would say, what specialties and what disease states lend themselves to emergency telemedicine care, and which ones there's no substitute for having a person physically present.
As you're doing that calculation, so what are you finding is likely to be the most resistant to telemedicine?
One of the areas where we found requires a balancing act between remote expertise and a local pair of hands is in intensive care. During COVID, one of the things we found is that our pulmonologists who were downtown, who were seeing hundreds and hundreds of COVID cases, had developed an expertise that wasn't available in any literature about how to tweak the ventilators to help these patients survive, because apparently it's different than the way most pulmonary critical care patients are taken care of. On the other hand, people in an ICU can follow those directions, but we still need somebody local to put in lines and to intubate the patient and to sort of do the minute-by-minute hands-on care that's required. And that turned out to be a good partnership between local intensivists or nurse practitioners or PAs, and then a very highly specialized pulmonologist who might be at a central center. And I don't think anyone will be resistant to telemedicine. I think we all just had to dive in when COVID hit. But I think there are specialties like that that will require a sort of local remote partnership to work.
Good. I want to follow up on that with my next set of questions. And Bill, I'll come back to you. In a recent Deloitte publication, you surveyed healthcare executives about the future of telehealth, and fully 50% thought that at least a quarter of all outpatient preventive long-term care and well-being services would move to virtual delivery by 2040. Do you agree, or maybe do you think that it's going to happen even sooner? You are muted.
Sorry, I think that's highly conservative. I think we'll reach that threshold much earlier. Elizabeth was talking about the fact that they're holding at about 20% primary care right now. Other organizations like Kaiser Permanente have maintained over 50% of their visits being of primary care variety being delivered virtually. So if you think about innovation cycles as being 7 years in duration, that's 2040 would be 3 innovation cycles from now. So we think that there will be dramatic advancements in virtual communications and virtual technologies during that time. And the majority of care will actually be delivered in home in all likelihood. Elizabeth started to talk about hospital and home, SNF at home programs. I mean, there would definitely be procedurally oriented elements to care, as Richard was talking about, that will always require in person, but we think that much more will happen virtually. And we're seeing plans now and insurance companies start to develop virtual first products so that they're selling into the market these products that not only reimburse for virtual care, but preferentially direct towards virtual services. So we think that this momentum is not going to slow. We think it's a much better way of delivering care for the reasons we all talked about, extending scarce expertise, meeting patients where they are, increasing contact with patients, being able to really have longitudinal touch points with patients and be able to interact with them, whether in person or through AI-enabled nudges, but really get to more behavioral modification in real time that drives health and well-being, as well as our ability to take care of acutely sick patients. So I think that for sure that 25% number is conservative.
And Elizabeth, you started talking about the hospital at home. If Bill's right, what do you think the hospital of 2040 or maybe as soon as 2030 is going to look like?
I mean, what's exciting is I think if we think about the types of admitted patients even we have, there's folks who again came in for a surgery who that's still going to need to be there, but does that recovery need to occur in the hospital? Potentially not. potentially you're there for 24, 48 hours, and then you're able to move home with still potentially a level of care where you're having someone come into your home to check on you, plus with monitoring devices. But you may be admitted to a hospital for 5 days for a procedure now. You might be in there for 1 day in the future. Think about the impact that could have on cost. I mean, I think it's just that's transformative. I think some traditional medical admissions where you're maybe, again, being monitored or on some sort of IV medication and in the hospital for several days, that could occur at home now. I think it's just so exciting. And then from us, I think we think about, okay, what is that going to do to our cost? It's obviously going to shift the reimbursement model, but then physical space. You know, we own 12 hospitals right now across the Chicagoland area. You know, are we going to need all that space in the future?
I was going to ask, just not too far north of where I live is Lake Forest Hospital. It's brand new. I don't know how much money you spent on it. It's a beautiful campus. Are you going to be converting those into condos?
Yeah, I mean, we'll see. I mean, I think, you know, I think when we think about the outpatient space, I think for sure we look at some footprints that we won't need in the outpatient side. We do have a few specialties where we have so much demand. We actually do see that the virtual care is just going to help us see more patients. We'll still be able to fill our offices. And then if we have virtual providers, we'll even just be able to see more patients physically. But that's a very unique set of areas where we have a high demand. But for sure, I mean, I think outpatient facilities, we have a huge network of urgent cares. I think virtual care is certainly going to transform the urgent care market as well. So if you have, if you're wondering if you have strep throat and you call in and give your symptoms, you know, do they need to do a test or not anymore, and just something, or is there a way to do that at home? There's a lot of, I think, a lot of transformation that will happen for even with our physical space, for sure.
You mentioned about potentially being able to see more patients. I want to come back to that. But before we do, I want to talk to Richard about the future of the doctor. Mm-hmm. And so when I grew up, the doctor, the model for me was Marcus Welby, the television doctor, the family physician who, there's the opposite of telemedicine. He went to patients' homes. And to some extent, that physician-patient relationship is still central to healthcare delivery. What do you see as the future of the doctor in a world that's dominated by telehealth?
Well, I think it's part of a trend of what's called medical consumerism, where the doctor-patient relationship, which for better and worse was this, it was almost a situation of doctor worship, which as a doctor I was okay with, where it was a sort of, there was a very deep connection between the patient and the doctor, and it was a very unbalanced one where the doctor was felt to have all the power, the patient was sort of the subject waiting to be seen by the royal physician. That's changing, and the fact that patients of mine show up for their televisits while they're at Starbucks is an indicator that that relationship is perhaps not quite as sacrosanct as it used to be. Does that change the meaning of being a doctor? Yes. The meaning of being a doctor has always changed with the rise of technology. Doctors used to be there to help comfort you when you were dying, and there really wasn't a lot else that we could do. And with technology, there's tons we can do. And there's probably a little bit of hands-on hand-holding that's been lost. And that evolution is just part of being in a dynamic specialty. So I think we all just have to live with it.
Okay. A question for Elizabeth, but I'd like you all to think about this, is the point you brought up about being able to provide more care. Where you're thinking of telemedicine, I think mostly is kind of substituting for existing care. Instead of going to the hospital, you have it done at home or somewhere else. Are there ways in which telemedicine can complement existing cares? Are there areas where it could lead to more healthcare delivery rather than simply displacing where the care is delivered?
For sure. I think that's what we, one of the things we are looking at is there a way to capture, particularly potentially a younger generation who do see healthcare as a little more transactional? And if we are able to identify, complete some of those initial visits virtually, how do we keep them then within our system for other other pieces of, other episodes of care long term. That's one thing we're looking at. But I think as we look at across specialties, I think we are trying to talking with the physicians about, okay, is there a new type of care that you can provide now that you couldn't before? I think a lot of hospitals, are looking to expand something like a second opinion program or a virtual visit, and it would now allow you to get, an opinion from a provider in a different part of a state potentially, which may or may not have existed before.
Richard, do you want to add anything?
I agree with everything Elizabeth said, but I would sound a cautionary note. There's no question that the whole internet revolution and telehealth, both video and electronic communications, adds to the amount of access and the amount of healthcare that can be provided. But that is not the same concept as better healthcare or better access. For example, it is not an efficient use of physician time, to come up with a trivial example, for everybody with a headache to have a televisit with the chairman of neurosurgery at Johns Hopkins, right? That would be too much access, not good for the patient, not good for the healthcare system as a whole. So when we enhance access, we need to do it intelligently and not lower the little bit of activation energy barrier that kept a lot of trivial things out of doctors' offices. We really, a couple of days wait to see a primary care doctor in some cases allows whatever the problem is to just go away, as opposed to generating $100,000 worth of tests for something that really is trivial. So I think we have to be smart about allowing more access.
I remember my primary care physician mentioning that 90% of everything that he saw was self-limiting.
Right.
And telehealth might make it too easy to have expensive stuff done. Bill, do you want to jump into this?
Yeah, I think if we're smart about it, though, that we can route people to the right level of care at the right time so that they are getting the appropriate level of care, right? And to your point about things being self-limiting. And, I think Elizabeth brought up a great point about disintermediation of the physician-patient relationship. But a lot of that has to do with lack of access. So if I'm only available in my office from 9 to 5 and I'm booked most of that time, somebody is much more likely to go to an urgent care center or call Teladoc or use a substitutive modality because they have some urgency to what they want to have accomplished. But if all of a sudden I am available because I have these other means of getting in touch with me, you can text me, you can email me, you can call me, and by the end of the day, I'm back to you or somebody from my team is back to you, then you're more likely to stay with that physician because you do have access and you are developing a relationship, shared understanding of who that person is and the relationship that you have. So in a lot of ways, it can enhance that relationship. And you talked about Marcus Welby. This is a great way to do house calls again, right? We can go with virtual services and people don't have to leave and they can be engaging with their caregivers at the same time. And those caregivers don't have to be there physically. Somebody in Chicago with a parent in Florida, now that parent, that child can go to that parent's visit every time without having to travel. So there are some ways I think that this will enhance and further integrate the relationship of the patient and the physician.
So I'd like to talk more about access, but this might be a good time to start taking some questions from the participants. And let me remind all the participants that if you have a question for any of our panelists, simply go to the Q&A tab on the bottom. Hani is monitoring them, and Hani, you have a few questions already, so why don't you jump in?
Yeah, I'm actually going to ask some of my own questions. This is a fascinating conversation. I thank all of you for being here today. I want to go back to the point that David raised earlier about sort of additional service, I guess, versus the way I would phrase it is how much of this is replacing physical visits that would have taken place anyway versus being in addition to it. So is it substituting or is it complementary to the main visits? And I ask that because I want to predict the travel demand at the end of the day, how many trips are taking place, right? And so if I had 100 visits, let's say, per day that were happening pre-COVID or under normal circumstances, And now, because of technology, et cetera, I'm seeing 150 visits, okay? What I'd like, leaving aside growth, just more people who are sick, et cetera, but out of those trips that would have been 100 trips before, now let's say we have 150. Are those going to be, let's say if out of those 75 or half of them are still physical, but now I have 50% that are in fact virtual. Are they essentially, do I have just 50% more consultation because it is virtual, it's easier, I don't have to go there, or essentially are we just replacing trips that would have happened previously? That's my question. Whomever would like
Sure.
to, would like to take it.
I can,
Go ahead, Richard. Go ahead.
I was going to suggest that there's probably overall more volume, but less of it has to come in. And I would cite an example that most doctors prefer, I think, seeing patients in person. But there's a large cadre of APPs, ancillary care practitioners, nurse practitioners, who would love to have a practice that's entirely remote, that they could do from anywhere, that they can do on their, set their own hours. And so I think a lot of the things that didn't need to come in, but still need to be checked up on, will be done remotely, and we will be moving the more complex things, the things that are procedural, into in-person. So I don't know that it'll lead to more trips. It'll lead to more healthcare volume, but I don't know that it'll lead to more.
So in other words, I probably would not have gone to see the physician, but now that I can consult him or her, via Zoom or by phone, I'm doing that. That's extra volume, as you call it.
Well, but you might have gone, and it would have been a waste of time, gasoline, parking, and healthcare resources for something that's relatively minor.
Well, that's why I'm comparing it to a sort of a pre-telemedicine reference point, I guess.
Sure.
Yeah.
Yeah, I mean, I think that most people don't like to go to the doctor's office, you find. So, we were talking to one of the physicians at Dana-Farber, and they said, do you think my patient wants to drive into downtown Boston, find parking, pay for parking, wait an hour next to a bunch of sick people in a waiting room to see me for 10 minutes and then, have to navigate the trip back home, where they can have the same experience with a 15-minute video visit? I mean, they said the genie's out of the bottle. These people are never coming back to wait in my office anymore. They're just gonna call me now.
I think the only thing I would add, I think Dr. Bernstein mentioned this, is that there still is, we still see a strong preference on the physician side. Despite Bill, I completely agree that from a patient, we have the same downtown. Our biggest complaint downtown is parking. No one wants to have to park in downtown Chicago. But I do think there's some cultural shifts still to happen with physicians. And I also think the way we think about quality and we measure, a lot of that is still based on an in-person reaction. And I think those are some additional things that are going to need to come along as we think about continuing to have this transformation.
Yeah, there's definitely a cultural side of this, and physicians do have to, I think Kaiser calls it website manner instead of bedside manner, but developing that presence and being able to cultivate relationships through virtual means is different. It's definitely different.
So Elizabeth, are your patients now able to avoid having to sit in the waiting room you just sit in front of their computer and wait for the Zoom?
Yep, in many situations, yes. Yeah, so that is, I think many times now, again, I think when I was talking about, we're working with each specialty to say, okay, how do we are still letting the providers in many cases drive what we're offering as telehealth, if that makes sense. So we're going to oncology and saying, okay, many of our oncologists are going to say, for that first patient visit, I want to see them in person. I want to talk about their care plan. I want to spend an hour with them in person. But then as we're checking in, I can check in with them virtually. And for us, a lot of people might live an hour and a half away, come downtown and are getting treatment, prescribed by one of our downtown oncologists, but they're getting the treatment at one of our suburban centers. And they can then do virtually that check-in out there and maybe once a year come downtown versus every 6 weeks. I think that's some of the transformation that we're starting to see.
So is there any data on outcomes when, say, the first visit may have been done virtually versus in person? Because I can certainly see the follow-up meetings, where you're just checking in on progress, et cetera, doing that by phone or Zoom or whatever. But that first visit, particularly for more serious, I guess, ailments, seems to be or to be essential. But again, is there data on outcomes and instances where the first visit is in person versus it's virtual?
Well, there's certainly data in the emergent world of stroke. Now that's a little bit different than what we've been talking about, but we know that having telemedicine available, teleneurology available to treat stroke patients treats them faster. Outcomes are better because the treatments are powerful if you get them up front. The treatments are given more. It's safer because there's a higher level of expertise. So at least in the emergent setting, there's nothing. It's so much easier and safer to have the doc beam in than to get in their car and drive in to go to the ER.
But I honestly think it's too new. As we're thinking about providing these complete episodes of care with some in person and some virtual, I think we're not there yet to have that data available. I'm sure there are a number of studies going on about this right now.
And it's also very hard to measure health outcomes. It's very hard to impact outcomes. Most of our treatments barely have an effect on outcomes. So for a change in sort of visit venue to have a change in a hard outcome, that's a tough one.
So do we draw blood by teleportation?
Well, soon we'll be able to draw blood just by a finger stick, though.
Yeah, I hear you only need the tiniest drop of blood in order to do hundreds of different tests.
I was going to say, I don't want to bring up bad memories of or bad blood.
Honey, have we got any questions from the participants?
I'm not seeing any yet. Oh, hold on. There's a couple. How much are you targeting these solutions to people who have significant transportation access barriers, and what results are you seeing with those groups? And this is from Dina Wolfman-Baker.
Yes, I think a lot of times, especially in our elderly population, these programs have been targeted to those that are unable to travel, and you'll see more intensive programs such as those as ChenMed or Oak Street that are starting to mobilize more and more to patients' home rather than have the patient transported. So I think they started with the notion that we would send transportation out to the home to bring the patient into the physical location. But more and more now they're engaging in virtual services so as to not to be so disruptive. Plus you can, while in the home, check on chronic disease state monitoring or monitoring technologies to make sure that they're working appropriately and hooked up so that you can keep in touch with your patient even when you're not there. You can get blood pressure readings, you can get weights, you can have an interaction with them, you can prompt them based on those results. So we're seeing more and more of that activity in that space. And I think the other big population that is on the forefront here is those that are in need based on social determinants of health or our Medicaid population. So how do we treat that group of patients differently and meet them where they are and make it easier for them to access through virtual means using technology? So I think that those are two areas where we're starting to mitigate the transportation issues. Elizabeth or Richard, anything you would add?
No, I would agree. I think we're focusing on both of those populations, particularly around, like, for example, ED follow-up. So patients who come to the ED and then need a follow-up, we're really focused on trying to offer some of that virtually because we see a high no-show rate of people coming back to campus for that kind of care.
One of the hybrid models we're developing is where we have what we call a telehealth studio that could be placed in say a low access neighborhood so that patients who maybe don't have Wi-Fi at home, they maybe don't have a smartphone even, can come to this local site, sit in a room, and their doctor who saw them when they had their emergent heart surgery downtown can beam into this room in a hardwired, almost closed circuit TV situation and have a remote interaction with a patient who is not set up to do that at home. So that's in between a fully virtual visit and an in-person visit.
So there's another question. I'm sorry, David, you want to go?
Yeah, I
ahead?
just want to follow up. What about patients with whom, well, patients who don't have established relationships with providers who are at the forefront of telehealth, especially in say, rural areas where we know access to medical care is a problem? Are you or others reaching out to those communities to give them this alternative, or are they still going to be lagging behind?
So one thing we have to consider still with telehealth is licensure requirements. So one of the things that is still out there is states monitor physician licensure. They're licensed for a state. And now some of this is waived in the public health emergency, but we're really at a tipping point of figuring out what's going to happen after the telehealth emergency. But right now, for a physician to provide care, the patient needs to be physically in the same state that the physician is licensed in. So for example, us being, we have locations throughout the Chicagoland area, many of which overlap into Indiana, Iowa, Wisconsin, more rural areas. For us, right now, again, there are some waived requirements, but pre the public health emergency, for our physicians to provide care to a patient virtually in Indiana, they needed to be credentialed in Indiana.
So
And
Bill,
that's really, I think, a fundamental administrative
yeah,
item here that's going to have to be resolved.
and we're going to probably have some time to talk about some of the other regulatory obstacles to bring this to fruition. But Bill, you've been monitoring the national scene. Are you seeing telehealth having an impact on rural healthcare?
Yeah, definitely. And I think Elizabeth did, mention an important barrier that had historically has been there. But as she said, I think we're at a tipping point, and with this administration, there might be some changes. We have seen states band together to create a shared licensure in some states that are more rural. So particularly in the west side and the Mountain West, those states have banded together to provide a common licensure, and I could see that happening in other states as well. But where there is the opportunity in large states with large rural populations like Pennsylvania, as an example, we are seeing those large academic medical centers or medical hubs are able to reach out into the more rural areas. And as technology gets better, even in the low connectivity areas, the connections are good enough to allow even video visits to occur now. So we're able to offer video even in 3G antenna driven environments.
So Hani, I was going to ask you a question, actually, if you don't mind.
Okay.
So correct me if I'm wrong, but one of the reasons that people often don't choose to live in a rural area is because of access or concerns about access to healthcare. And based on what you've heard so far, do you think that telehealth could make rural living more attractive?
I think it's, I mean, in general, all the developments in information communication technologies have made rural living more attractive. You still have to, to go to the major centers for oncology, et cetera, when you need those. But for a lot of facilities, absolutely, I think, I mean, and there's already evidence of that we see. But we do have quite a few questions.
Good, let's turn it over then.
One is from Professor Marconi, and he asks, is there a way to optimize physical versus the virtual visit decision? And if so, what may be the main factors, and who should make that call? Should it be the patient, should it be the provider, or should it be insurance company? So would like to take that.
I'll jump in first, I guess. I would say that, as always, the patient should have the first say. I think that the patient should have the first preference, and then the physician, based on the complaint or the presentation of the patient, should have the right to then say, I'm sorry, but you have to come in for this. This is not something that I feel comfortable treating over the phone. The plan should have the least say
Yes.
and where and how care is delivered.
Yeah, that was exactly our experience. We started out in the pre-COVID days trying to make an algorithm for figuring out who could be seen in person and who couldn't. And it was much simpler to just say everybody can be seen virtually as long as the patient understands. The doc may say, I have to see you in person to take this any further. What we don't want, though, is for the patient to wait 3 months for a virtual visit and then another 3 months to actually get to the punchline in person. And so we had to change our scheduling a little bit to make that happen.
So we have another question from Professor Susan Shaheen of UC Berkeley, again, dealing with the access issue. And she asks, how does telehealth impact costs to patients? Because this could be a significant determinant for underserved communities to seek care. Would like to.
So I can start. I think, from a patient perspective, I think even just some of the simple things around the cost of transportation, physically, just thinking about, again, we were joking about, but it really is, in many of our patients, a pretty big deal to come downtown to our facilities and on site, and to take that off the table could be, just thinking about kind of that side of the cost of care. I think if you look at the other side on the reimbursement, and just looking at kind of the overall, the way that the insurance plans are going to reimburse for this and what that's going to mean for the cost to patient, I think it's still, right now is remained fairly similar to an in-person visit. I think it remains to be seen long-term what that's going to look like.
I think, Hani, one of the other big opportunities is to influence wellness. And, we've talked a lot about chronic care, so more secondary, tertiary, or even tertiary and quaternary prevention. But when we start moving up that chain to really secondary and even primary prevention, we think with wellness tools, virtual wellness tools, with remote patient monitoring, with greater patient engagement, that there is the opportunity for a wellness dividend of over $1 trillion within the next decade, if as these technologies are rolled out in a meaningful way.
Other comments on that?
I have to say, I know as much about healthcare finance as birds know about ornithology, but it seems to me that unless the overall healthcare system changes to be more equitable, no amount of technology is going to deliver that kind of dividend.
Well, that's a great point, Richard. And our point of view is that a lot of the technology will be directed towards increasing equity. You're absolutely right. We think that is one of the most important things that we have to think about as we develop these new technologies and new ways of outreaching, is the equity quotient, because you're absolutely right. So if we continue to do what we're doing, but with new technologies, it will not happen. There has to be that new model, that new understanding to recognize the full benefit. Absolutely right.
So one key in all of this is that CMS, Center for Medicare and Medicaid Services, issued reimbursable procedure codes for telemedicine. And normally the basis for determining the level of reimbursement is based on things like physician effort and the cost of maintaining the office, or the hospital's effort and the hospital's overhead that's allocated toward a procedure and so forth. I suspect, given how quickly they put these codes in place, that the reimbursement levels we're going to see in the long run may not at all resemble the levels today, and they might in fact be much, much lower, which of course is going to change your calculus as to how aggressively you want to offer telemedicine, but also change the patient's decision as to whether they can afford to receive the care. So I think that's going to unfold very rapidly in the next couple of years as CMS gets its arms around the expenditures.
So staying with the issue of payment, reimbursement, and so on, we have a question from Lanny Wilson, who asked, do you believe that the Illinois General Assembly will stand up against the health insurance industry and make telehealth payment parity permanent?
Wow. I'm not even sure that payment parity is what I suspect that telehealth is cheaper. Right? It doesn't require all this bricks and mortar payment. It ought to be paid for, right? If it's thought to be a clinically appropriate thing to do, that gets paid for. Even the most stubborn health insurers generally go along with that viewpoint. What the level of payment is the question. I think insurers wouldn't want parity. They'd want less than parity.
I think plans are grappling with that issue, David. So, I think they're we don't have the actuarial models to understand how to pay for these services yet. As Elizabeth mentioned, we're so new into this, but As those actuarial models mature and there's an understanding if there's going to be overall cost avoidance, long-term versus near-term effort, do I pay on par to help the cultural shift of physicians using the service and then start to ratchet it down over time? Do I start with an 80% payment mechanism based on my actuarial models? The other thing that plans are grappling with is how do I guard against fraud, waste, and abuse? So unfortunately, a lot of virtual health services could be ripe for fraudulent activity. And even non-fraudulent activity of saying, I talked to a patient in the morning on the phone and I billed for that, and then they came into my office in the afternoon and I billed for that. So, you know, building some of those kinds of contingencies into product design and benefits, understanding the actuarial implications from overall cost are where plans are grappling. But I do think that the fall for most states, at least in the near term, is going to be as well as CMS is to be on par reimbursement in the near term, and then use the next 18 to 24 months to learn the things we just talked about so that we can reimburse at a responsible level going forward. So hopefully that'll be what happens. That may be way too logical for government, but I think a good way forward.
One aspect I would consider is that for some of our pilot programs, when we started this pre-COVID, we were able to make sure that the docs were themselves would be paid for their time the same as an in-person visit. And it was very hard to get people interested in doing this. But when the choice was do a virtual visit or you don't see any patients at all of a sudden everybody became a true believer. So I don't know where that fits into Bill, what you were saying, but it took a fair amount of pressure with a gun to your head to make a lot of docs jump on this bandwagon.
Do you think the job satisfaction of physicians is going to be jeopardized at all by this move to remote practice?
No, I don't think so, because for those who really want to see patients in person, there's no shortage of patients. And for those who really prefer doing it on a screen from Maui, there's no shortage of patients to be seen remotely. So I think it gives more flexibility and potentially allows people with different career expectations to become doctors, to become practitioners.
But then when you mentioned the, I guess the tiering, that insurance may first require a telehealth check before you go to the, physically and so on. How would that work with what you're now stating, that there's no shortage of either type?
Well,
yeah, go ahead, Richard.
No, you go ahead, because I'm not sure.
I think that, what I was talking about with the tiering is, first of all, that hopefully you have, and again, this will something that evolves through our artificial intelligence and machine learning, is the appropriate routing based on a triaging. So virtual triaging to get the person to the right level of care. Hopefully that destination is appropriate, the care is rendered, and that's the end of the interaction. If somehow the person got routed to the wrong destination and they needed to be seen, then there would be no payment for the virtual interaction and just for the in-person interaction. So that's the kind of protocols that they're looking at developing to make these virtual first products tenable and responsible in the market. Does that answer the question?
Yeah, I think so. So the related.
Can I jump back in? Our panelists, I'm sure, are familiar with the concept of episode of illness payments or bundled payments. It seems to me that and that's all part of what I think most people have heard of payment reform, that telemedicine would seem to be just perfectly fit into a world where we move into these new payment models.
So then, as we look at, you mentioned the physician in Maui. Okay, yes, they could be in Maui, but then given the sort of cost squeeze and pressure and so on, couldn't that same physician or a different physician be in a low-wage country?
Yes.
In India and Cuba or whatever.
Yes. Yeah, to David's point about value-based care, I mean, virtual care was made for value-based care. And that's why organizations like Kaiser have been so far in the forefront, because they have a closed value-based system. As reimbursement has come to more service-based organizations, they've picked up on telehealth as well, because now from a financial perspective, it's doable. It's able to be implemented. But even again, when I was at UPMC and we had a physician who was doing laparoscopic liver resection, we wanted him doing laparoscopic liver resection. We didn't want him driving to satellite hospitals. So all of the follow-up visits that he did were telemedicine. And the people that he visited were happy because a lot of them were, to Elizabeth's point, coming from all around the tri-state area. And then rather than having to make a 2-hour drive, they were just able to get on a television, on a monitor and see their world-class surgeon. So, those kinds of value-based constructs are much easier to implement a telehealth program in than in a more fee-for-service or service-driven organization. But you're hearing from Elizabeth and Richard, even in fee-for-service with the new regulations and reimbursement practices, it even starts to make sense there.
And I think really to implement really what we're talking about here is, I think, Bill, a point you made a while ago about almost needing someone to help direct patients to that appropriate level of care to start. So what we're looking at is starting to put a triage layer in for even people calling in, with an urgent issue, to say, okay, have a nurse available, talk to them to say, let's immediately get you a virtual visit on with a doctor right now. Do you need to go to an urgent care, or should you go to an ER right now? Or do we schedule you for an in-person visit tomorrow? And how do we almost have like an air traffic controller helping people utilize the resources differently?
So there is a follow-up question to you, Bill, from Brett Johnson, who's asking, what is the state of AI and machine learning to help drive triage decisions?
Starting, all right, we're in the very infantile stages and the tip of the iceberg, but there are a number of vendors that are out there and organizations that are developing algorithms themselves, and that are really starting to hire their own data scientists. It's hard to separate AI from the cloud revolution. So the ability of the cloud to render large data sets and for data scientists to wrangle large sets of unstructured data sets to come up with new ways of understanding patterns and paradigms, we're at the tip of the iceberg with that. Now, Richard alluded to earlier equity, and we have to be very careful with these algorithms and make sure that we're not amplifying bias in them. But as we get smarter about how we develop those algorithms, as we get more data sets, as cloud computing is more available to smart people and smart organizations, we will enhance those algorithms in real time. There will be an acceleration of being able to do that. So we have started to see them doing the virtual triage in an automated fashion. And I think that will increase as we move forward.
Anybody else care to comment on that? Okay, we have another question that's technology related from Ralph Vandenhagen, who asks, it would seem that a technology setup may be necessary for many virtual care situations. Is that being considered? And I believe there are probably two aspects to that. One, technology at the patient side, those who may not have access to it, but also special technology that the provider may require for examination. And I'm just, anybody care to comment?
Yeah, sure. There are a category of devices that are given to patients that are video visit enhancement or video visit facilitation tools. They can range from simply a smartphone for some patients who don't have one that allows a video connection, but there are a number of them that include a stethoscope that's Bluetooth connected to the computer, or an ophthalmoscope or an otoscope that allows a physical exam better than you would get just from video. And you can buy one of these devices at Best Buy and then use them to connect to any of a number of online care providers who will beam into your device and listen to your heart rhythm and listen to your heart sounds and so on. So I'm not sure if that answers the questioner's intent, but those
And also just like a very fundamental piece that people don't think about, we have over 1,500 exam rooms that do not have a monitor that has a video feed on it. That was just never something in our infrastructure when we built our physical spaces. We didn't require a monitor have a video on it. Just, I mean, that's something we're replacing. We've gone through but that's a cost that a lot of health systems just didn't, very fundamental piece of this.
Is that an obstacle or an impediment to further deployment?
It has, I think it's definitely something our providers bring up, is that, they have to move to a different space when they think about their day. If we're having their day be a mix of in-person and telehealth, they're using an iPad next to the computer where they're documenting on. So honestly, those kind of logistics, everything changed so fast. It's taken us a while, to get caught back up.
I would have to imagine at a less affluent healthcare system, this could be a huge barrier.
So these devices that you could buy at Best Buy, some of them are probably pretty expensive. Are we imagining some kind of divvy program for these devices where there's some place you could rent them from and then return them when you're done? Seriously.
Yes, I could imagine, well, they're a couple $100, which for a lot of people is expensive. I can imagine if you have a surgical procedure, the surgeon sends you home with one of these, does a few post-op visits, and you've left a deposit to mail it back. So that's sort of like what you're describing.
And even some of those, to your point, Richard, they're developing now patches that can be worn for 72 hours under the armpit that transmit temperature. So after your surgery, you just put this patch under your arm, you change it 3 times, and you have a week's worth of temperatures being sent to the physician. And if there's a spike, the physician is made aware. This thing has even got predictive modeling in now to predict when a temperature is going to happen. So those kinds of, and that's just a plaster that the physician gets reimbursed for administer and gets reimbursed now for tracking and doing counseling based on new codes. So, that's something that could be paid for today. So I think, again, if we think about those 7-year innovation cycles, we will probably overestimate what's going to happen in the next 7 years, but we'll grossly underestimate what's going to happen in the next 14.
Interesting. So we have a question from Amy Stearns from the U.S. Department of Transportation, who actually wants to ask exactly the same question I was going to ask. So I'm going to ask it my way, Amy. I've done some expert witness work in my life, and I can just have this vision of the lawyer from New York City firm, and talking to the physician, medical professional, and say, well, doctor so and so, did you actually examine her in situations of whether it's malpractice or whatever you want to call it? I mean, liability is hanging over this whole issue. How does liability really factor into virtual care, where the patient is self-reporting, where you may not have seen that bump that the patient thought was nothing, or where they're just reporting their own readings and they didn't read the the blood pressure monitor correctly? Are there precedents at this point, or is how are you protecting yourselves?
I don't see the situation as all that different from an in-person visit where you conduct a physical exam, but the extent of a physical exam is endless. You could do a physical exam for 4 hours, or you can do one for 4 minutes. And the same thing is true with a virtual visit. Number one, you can get sued no matter what you do. And number two, you're always dependent on what the patient tells you, which can change from one doctor to the next. And you're always dependent upon your judgment and knowing when to go further. I don't know that doing things virtually changes that fundamental equation. The question I've always wondered about that's related is, what if an AI steers you to a visit tomorrow for a heart attack that you're having today, and there was no one involved at all other than the person that wrote the AI program, which then taught itself over the course of a few years? You can't sue a neural net. So that's a question I don't think is resolved.
As you're saying, there's definitely ethical questions about AI, and so far that's why they're still just making recommendations that are still interpreted at the end by a human being. But I'll turn it a little bit on its head, Hani, about, being sued. As we talked about cloud computing and the price of storage being so low, you could store the entire video visit as a visit. And so rather than relying on people's memory or what was written in a document, you can go back and look at the actual visit and see what was said and what was done. Ambient documentation with voice recognition and natural language processing make it easier and more thorough to do documentation and capture what's happening, as well as a backup of the actual video or audio of the visit itself. So there is an opportunity perhaps to be even more judicious about what is and is not malpractice based on the way that we could store records in the future.
I have to say, as a practicing physician, I would hate having all of my interactions with patients taped. When patients come in with a tape recorder, I usually say yes, but it changes the nature of the conversation because you're speaking in a sense on the record, and it dehumanizes it. And it would be a major culture change to have every interaction transcribed and stored somewhere.
Mhm.
Getting back to the notion of malpractice, there will be a testifying expert who will look at a video and claim that there's something obvious that should have been noted on it that you didn't note it when you were actually with the patient.
In your question, you did mention, what if the patient looked at their blood pressure device and misread it? One of the things we are looking at is how do we integrate device data directly into our electronic medical record? So how do we allow those devices to directly talk to our EMR? And that way, when the patient comes in, the doctor can see, oh, you've been checking your blood pressure every day. Here's the trend of what it looks like. Here's what it is in the office. But that may, break down some of that ability to misinterpret the data.
So we have one more question here, again from Lenny Wilson. Dr. Lenny Wilson, who's an MD, asks, and this is kind of going back to your introduction, David, about the articles predicting developments in that realm. He basically says a robotic surgeon performs her or his surgery at their console in the corner of the room. Might there be a day when the most experienced robotic surgeon might perform surgery from their office in Chicago for patients in remote locations around the country?
That's happening right now.
Exactly.
Yeah, and it's only going to be more prevalent, more successful with 5G technologies that are right on the horizon. So any lag or latency that may have prohibited advancements before will be, for the most part, relegated by 5G. And then again, the next technology and innovation cycle will have 6G and 7G.
Right this second, there are remote devices that allow cardiac catheterization and angioplasty with manipulation of the catheter by a physician who's somewhere else. Right now, on a hardwired network, such as we have between Northwestern Memorial and Lake Forest, but on a 5G or 6G network, it could be on just the general internet.
Could somebody comment more about sort of the e-health side in terms of various you mentioned earlier with stroke. There's been several companies, Dexcom, others that that have gained a lot of popularity, I guess, during this pandemic. Any developments on that front that you can comment on, or that we should be aware of, that may impact ultimately one's behavior?
Which company did you mention, Hani?
I mentioned Dexcom.
Dexcom.
Yeah, which tracks for diabetes, I believe. That's constant monitoring.
Yeah, I mean, I think if you look at the space in general, where private equity and VC is spending money, they have spent $20 billion in wellness and disease management types of companies that are remote. And to be fair, they put Peloton in that category as a wellness company. So, it's pretty broad, but it also includes like Talkspace and Headspace and companies that do actual disease management, like you were talking about, or even Livongo that was acquired. But private equity and the private sector has invested $20 billion. The healthcare system itself has only invested $1 billion. So that gap will close over the next 5 to 10 years as healthcare continues to invest on its own in wellness and disease prevention and disease management. But those technologies will become more pervasive, and we think that they will be disruptive. Again, you will start to see care being offered on Peloton through your Amazon website. It will be the retailization of healthcare is another trend that we think is going to really increase and accelerate.
Okay, so we take, at this point, I'll turn it back over to David.
Yeah, it's something that's been kind of lingering for a while. Electronic health records got brought up earlier, and I recall probably about 15 years ago, the real excitement about electronic health records was beginning. This famous article published in Health Affairs predicting $1 trillion in savings over the next decade. Everybody was an enthusiast, though in the back of their minds, everybody also had doubts. Now we know that electronic health records have not produced $1 trillion in savings over the past decade. In fact, it's hard to find any evidence they produced any savings at all yet, though I think that's finally changing. What are the obstacles that we haven't been talking about that would stand in the way of this remarkable vision that you've all been presenting?
Well, I think a big obstacle is simply the way our whole system is set up to do better for people with money than people without money. We talked about this earlier, but it's still the first people to adopt telehealth in my own practice were the wealthy ones who could figure out how to get this stuff done or have their lawyer get them online or something like that. And so I think this may turn out to be, and you know, if your healthcare is provided on a Peloton, I think there are more Pelotons in Lake Forest than there are in the south side of Chicago. So a lot of this can amplify the inequities that already exist, and in the end, make young, rich, healthy people the same young, rich, and healthy they are, and really not touch the vast majority of people who need the help.
So I'll agree completely with Richard again on the equity front and making the technologies more affordable for and accessible for all. And I think there are some simpler technologies. Analog phones with text messaging has proven to be valuable for follow-up all by itself. So I think more attention in that space and the issue of equity. You talked about, David, value-based care. So I think acceleration of value-based care could accelerate virtual health. Any, revision back to more fee-for-service driven enterprise or industry would be an inhibitor unless the reimbursement stays trending the way that it has. I think the opportunity that differentiates this from electronic medical records is the human factor. So one of the things that is very different with these technologies and the way they're being developed and deployed is really painstaking attention to detail about simplicity and the human interface. And so the intuitiveness of these devices as we continue to develop them for patients to use them easily, for it to fit into their life flow, and same for physicians as we start to develop more intuitive workflows with these devices and with these setups. We think that the electronic medical record could actually be relegated to a true system of record rather than a workflow system. And workflow will happen on top of the system of record based on this ecosystem of virtual and AI-driven enterprises coming together. So again, probably an overly rosy picture of the future, but one that we think is certainly possible.
Yeah, I would echo that and just say patient engagement. I do think just it's certainly still, I think, to Richard's point, there's certainly still equity issues, but there is just a bigger push on the everyday person to be more engaged in their health. Now, whether that impacts their behavior or not, that's going to make a change is still to be seen.
You see this as generational, that the over 50s want to see their doctor, the younger 40s are used to doing everything on a little handheld device?
No.
When we looked at our data, yeah, we've seen a higher percentage of older people. Now that could be the COVID environment where people are not wanting to come in to high risk situations, but we've seen a higher utilization of telehealth from older.
And how about from the physicians? Are they all equally enthusiastic, and do you see any barriers there?
There are still grumpy old men who
I
don't
represent that group, and I wanted us to be heard.
who don't want to do this. But on the other hand, there are a lot of physicians practicing into their 70s who don't want to come to the medical center either. One of my colleagues in cardiology is 75. He does lipid management, doesn't need to see the patient in person to do that. It's labs and talking. And he's converted his practice entirely to virtual, and it allows him to do it and yet remain safe. So I've just seen that people have a range of attitudes, but I haven't seen it systematically vary by age.
Well, I guess that brings us to the end of this very interesting and stimulating roundtable. If anybody has any final comments here for us, would love to hear those.
Let me just add my thanks to Hani's. It was a really stimulating. I learned a lot about an area I thought I already knew something about. So I really appreciate the chance to participate today.
Thank you all. And an announcement to our audience is that the roundtable will be available for later viewing, and it will be available through our YouTube channel. We'll be sending announcements about that as well. So.
Thanks for having us, Hani.
Very much. Round of applause
Yes,
to
thank
all
you.
our participants today. Thank you very much.